transepithelial. Okay. So in the next 5 minutes or so, I'll actually try and cover something very brief about treating and preventing post-PRK haze. I strongly believe that the best way to treat post-PRK haze is to prevent it, because once it really happens, there's not much you can do other than surgical intervention. There have been a lot of articles published about long follow-ups after PRK, and though post-PRK haze is something that a lot of people talk about, it is usually quite negligible. The amount of haze, even in a 20-year follow-up, seems to be less than 0.2% of patients. We actually looked at our data, and in the last 8 years of 11,000 plus eyes of PRK, we only had 29 patients who required an intervention surgically for removal of the haze. So that's about 0.24%. That's really, really low. So I think it's not a really problem. Even if you have haze, you have two kinds. You have the early onset haze that you typically see in a lot of patients in the first to 3 months after surgery. This typically disappears with an increase in the steroids and preventing exposure to UV light. The risk factors again are high myopic ablation as well as astigmatism correction, which is more than about a diopter and a half. The mitomycin protocol that we use is a little different from what is published. What we use is 0.02%, 10 seconds per diopter of correction that we actually use the mitomycin C. So the example is if you have 4 diopters that you're correcting, I use 40 seconds of mitomycin C on the cornea. What is more problematic is the late onset haze, and this is what you typically see in somebody who's prone to haze or somebody who has a tendency to form keloids. And this is the typical reticular kind of pattern that you will see in the haze, and you know that this is actually subepithelial in location. This is again typically seen in patients who have spherical ablation in the center. If you have patients who have the same kind of tendency, this is the other eye of the same patient, with a higher cylindrical ablation, haze tends to occur in the area of ablation, which is more in the periphery. Another correlation that is interesting is a correlation between the time of the year that you operate and the haze. It's interestingly seen that there is a peak of haze that occurs during the summer months where the UV exposure is more. So maybe if you have patients you are operating, you probably should advise them more UV protection during summer. So what do you do when you have haze like this? So this is an example of a patient who came in with central haze, operated elsewhere, but then this patient had about a -3 pre-op. So he had regressed to -2.5 and -0.75. Best corrected vision was 20/60. And you can see that the haze is pretty significant in the center. And even on the OCT, you see that the haze that is subepithelial, causing quite a bit of irregularity, and it seems as if it does impact vision quality as well as quantity. So simple way that I like to take care of this haze is earlier I tried debridement, I've tried using a diamond burr, both of those have not been very successful. So typically what I use here is I use alcohol because the epithelium is more adherent to the underlying fibrosis, and once I take off all the epithelial layer, I try to remove some of the fibrosis with my with debridement as well, and you can see that the bed is relatively irregular. And then I usually do a PTK treatment depending on the depth of the haze, typically about 25 to 50 microns. And once that is done, I check to see that there is no more haze left. Then I use mitomycin C for 2 minutes when you have haze that has occurred after PRK. And once you wash all of it out, then you're good to go. This is the same patient post-op day 1. You see that the haze is completely gone, and even on the OCT, the haze is completely gone as well. But again, this patient, 1 year post-op, you see that he has haze that's developed in the periphery now. That is because the PTK protocol of the EX500 laser tends to ablate more in the periphery than in the center, so you tend to get a myopic ablation. So we didn't put mitomycin C as much in the periphery as in the center, and that's probably the reason why he's developed haze in the periphery. But you look at his visual acuity, plus 0.5, minus 0.5, 20/20, and I think most patients who have haze after PRK will take that. So to summarize, what we do after PRK, late onset haze is relatively rare after surface ablation, best prevented rather than treated. So use mitomycin C and limit UV exposure seem to be the 2 caveats of limiting haze. Early onset haze, steroids work really well, but late onset haze also occurs with regression. So you need to be careful about treating the myopia as well. And most cases, if you just treat the haze, the myopia will disappear. You don't need to ablate for the myopia. So I found that the best intervention is PTK with limited PRK. so that you correct for some myopic refractive error as well as take off the haze that is there in the subepithelial area. Thank you very much.
Dr. Pravin, what's